Welcome. This presentation on gastrointestinal disorders forms the part of PT 741 Medical Pathology for students of the Doctor of Physical Therapy program at Marshall University. This lead-in presentation only introduces concepts and the approach to patients with gastrointestinal diseases and how it influences the body's movement system. The presentation is primarily on the symptomatologies that patients present with these disorders. The symptoms are not comprehensive in this presentation. However, there is a companion sway which I have linked below that contains all of the detailed information that you need for your course exams as well as preparation for your boards. Also, the relevant sections of this presentation will be highlighted in chapter format when you play this. As always, please play at 1.5 times the speed for optimal listening experience. Let's get started. The objectives for this presentation have been revamped, updated, and are matched with your SWAY presentation. They're on this screen. The companion SWAY to this presentation will be available to you from the link below in the notes section, as well as in your PowerPoint that you will receive through Teams files. As is customary for review of pathology, one needs an in-depth understanding of physiology of the organ system that is under study. We have had opportunity to look at the physiology of the gastrointestinal system via a previous video lecture. That same video lecture is embedded within your slide deck. I have also embedded it within this presentation, and it is for you to go ahead and review it. This is the video presentation that I spoke of and should be available to you from your PowerPoint slide deck. It is important to recognize, even if it has been said many times before, that there are disorders for which physical therapy does not directly treat. However, it is important to understand what are the circumstances that a patient presents with. These are the interface information between a patient and a clinician. A patient does not come with a diagnosis. They come with symptoms and signs of a system or multisystemic disorder. For understanding how to approach it forms the basis of developing your clinical skills in this area. Let's therefore look at the approach to the patient with gastrointestinal diseases. This section, for the major part, looks at symptoms and signs of GI disorders. So as I mentioned, there is no direct correlation between gastrointestinal diseases and physical therapy. Most consults are generated as a concurrent complaint of weakness. Complications can happen, and there are many depending on the underlying circumstance. Certain gastrointestinal disorders will contribute to interference with the movement system. It is for the clinician to figure out how that influence works so that they can address it properly. For that reason, it is important to individually understand every major problem with different parts of the gastrointestinal system. However, there are some common symptoms that make it most obvious that the problem is perhaps in the gastrointestinal system. Let's look at some of these common problems. So, a gastrointestinal disorder disrupts its primary or core function. So, what are the core functions of the gastrointestinal system is perhaps what's on the table to understand. So, the gastrointestinal system is primarily involved in the supply of nutrients. How does it supply nutrients? It absorbs these nutrients from the diet that we eat. Additionally, the gastrointestinal system also has immune functions. It has functions that aid in resisting disease. Perhaps the best example of that is the presence of acid in the stomach. The pH of the stomach is about 1 to 2, which is extremely acidic. Normal pH is considered, neutral pH is considered 7. So you can imagine how acidic the stomach environment is. Normal body pH is 7.35 to 7.45, which means it is a little bit on the alkaline side. So if pH goes down in the extracellular fluid, one would perish around a pH of 6.5 to 6.8. Therefore, when we are talking about a pH of 1 to 2 in the stomach, it tells you that anything that reaches that stomach is subject to being burned and dissolved in the acid. And that is how the acid serves as a part of the innate immune system. When there are problems with this situation, it can get either into a scenario of too much or too little, and each one will have its own sweet problems. Additionally, back to the absorption of nutrients, um, some nutrients are essential for producing energy. As we know, we eat to provide us with energy. However, we also eat to provide us with building blocks that are essential for life and health. Some examples of building blocks include the necessity for something like vitamin B12. Vitamin B12 is useful for the health of the spinal cord as well as for the production of red blood cells. So any mechanism that is involved in the absorption of vitamin B12 is going to impair its building function. Some GI disorders can also be life-threatening, and we will look at those as we go deeper into the study, and that will be on the sway that is companion to this product. The pathophysiology study of gastrointestinal diseases is unique to the individual diseases of the individual parts of the gastrointestinal tract. Therefore, it is impossible to be fairly generalized in discussing pathophysiology of such a vast system. Many of the diseases that are important for basic knowledge for entry-level physical therapy professional is discussed in this way. The very many symptoms that a patient presents with again are variable based on where the problem is and what the problem is. Regardless, a collection of such symptoms are shown on the screen. If you can go through this by pausing the video or looking at your slide deck, the first thing that should strike you is how vague they are. None of them point you towards an underlying problem. Figuring it out is a part of the examination of the patient, and in some cases, further investigative studies are needed. Similar to the vagueness of the symptoms, the signs are uh, those phenomena that you elicit as an outcome of your examination or your physical examination. Some of these signs can also figure as a symptom because a patient might relate it as one of the reasons that they have come to the clinician for. So the symptoms and signs are somewhat interchangeable as well as being vague, uh, as shown on the screen. However, some of these signs can be specific. For example, melena is the presence of blood in the stool. Now, the presence of blood generally indicates there is bleeding in the gastrointestinal system. It just does not tell us where exactly the bleeding is. However, one thing is fairly certain. The phenomena of melena makes the stool black. This happens because the bleeding uh, has happened sufficiently high up in the gastrointestinal tract such that the blood has been digested on its way down. When blood is digested, iron is given up, and that iron turns the stool black. The name of black stool is melena. Therefore, one thing is fairly specific, that it talks about, or at least describes, a bleeding in the GI tract, but it is sufficiently high, so it would be related to a upper gastrointestinal bleed, or UGIB as we say it. So that is fairly specific, but that is usually how specific it gets. So it is more vague than it is specific. A persistent and frequently occurring problem, perhaps most frequently occurring in the gastrointestinal diseases, is pain. Now, pain is a common complaint. This can be both local as well as it can be referred pain. You can look in the sway in the box to what referred pain is. Generally speaking, pain occurring from visceral origins, viscera is the organic structure within a cavity, um, will be either focal or it will be diffused. What that means is the pain can be localized to where that organ is, or it could be all over. The problem is that it can often be poorly localized. That means it will be there and it won't give you any hint of what organ it is coming from. So that is the biggest challenge with pain in the abdomen. A physical therapist may end up seeing patients with pain, and the way it is determined that that pain is related to musculoskeletal is that in musculoskeletal pain you can always reproduce it. This is most important because palpation of a site of pain is reproducible of the complaint. That does not happen in visceral pain. Another thing about pain coming from the viscera is that if it is not specific to certain conditions, then more often than not, it is centrally located. It is somewhere in the middle of the abdomen. That is shown in the zones that is discussed in the sway. These zones are epigastric, preumbilical, and hypogastric pain. As I mentioned, some pains are localized to quadrants which suggest a possible site of origin, and that is also shown in images in the sway. A good example of a localized pain occurs in pain of appendicitis, which occurs in the organ called the appendix, which is part of the cecum, or the first part of your large intestine. The general areas of pain in gastrointestinal disorders are shown on the screen, and that is what I refer to as also present in the sway. The pain pathways mediated via the sympathetic nervous system is shown for zones 1, 2, and 3 alongside. It is important during a examination of a patient to be aware of the site where the pain could originate from. Typically, we discuss the abdomen in terms of quadrants. The abdomen can be divided into either 4 or 9 quadrants. If you divide it into 9 quadrants, it can be fairly more accurately localized to the organs that should be in that zone. So zones are shown in the quadrants on the left, and they are numbered for reference 1, 2, 3 up to 9. On the right, you will see structures that lend to pain in each of these quadrants. It is enlargeable on your slide deck if you put it into presentation mode, or you can visualize a much larger picture if you navigate to the sway.
To this presentation on the acute abdomen. We are going to look at diagnosing the acute abdomen by looking anatomically and in a systems-based approach. Remember, this is a basic overview, and only some of the more common conditions will be mentioned in basic detail.
So, as you notice, your slide deck features a recorded lecture on the acute abdomen. An acute abdomen deserves its own special mention. As we stated earlier, pain is a common complaint in the abdomen. Abdomen is a large cavity and can hold several liters of fluid that can compromise many structures and their functions to the point where it may quickly threaten life. An acute abdomen, therefore, refers to a sudden onset of abdominal pain with nausea and vomiting. Acute abdomen is a condition that demands urgent attention and treatment. The acute abdomen may be caused by an infection, inflammation, vascular occlusion, or obstruction. The patient will usually present with sudden onset of abdominal pain with associated nausea or vomiting. Most patients with acute abdomen appear ill. The approach to a patient with an acute abdomen includes a very thorough history and physical examination. The location of pain is crucial as it may signal a localized process. However, patients with free air in their abdomen may present with diffuse abdominal pain. This can be picked up on auscultation as far as absent vowel sounds, and palpation may reveal rebound tenderness, which is also called Bloomberg's sign, along with guarding. This is indicative of the possibility of the presence of inflammation within the peritoneal cavity, which we call peritonitis. Peritonitis is the sequelae of many kinds of ruptures of structures within the peritoneal cavity, such as appendix rupture, or the perforation of a peptic ulcer, or acute pancreatitis, or ruptured sigmoid diverticulum, something called volvulus, among others. Everything that I just mentioned is discussed in more details in the relevant sections of the gastrointestinal anatomy as we go from top down from the esophagus to the anus. The relevance for physical therapy is that any sudden onset of abdominal pain must be referred for immediate medical attention. This is a medical emergency and the patient may die. Whenever we say medical emergency, that is usually the concern. Further reading references are also provided in this way. The gastrointestinal system also provides us with nutrition that fuels energy-intensive processes, and frankly, for work and exercise. Disorders of the gastrointestinal system therefore contribute to a lack of energy, which in turn is processed by the patient as a feeling of weakness or fatigue or lethargy. There is no workaround. A patient needs nutrition for energy. Even a Lamborghini does not move an inch without gas in it. Additionally to what I have just said, there may be blood loss in circumstances when there is internal bleeding in the gastrointestinal tract. This bleeding may be from the upper gastrointestinal tract or the lower tract. Regardless, if it is present, that means if there is bleeding and loss of oxygen carrying capacity, then uh, the PT relevance is that you should look for hemoglobin uh, levels in the lab values. Um, inquire in all of your patients the source of nutrition. This takes a more critical requirement in patients who are critically ill and are not able to eat by mouth. Insist on nutrition before increasing baseline activity. Additionally, patients with wounds and those with protein calorie deficits must have adequate nutrition by any means before they can be expected to move and participate in energy intensive processes of physical therapy. Another classic feature of bleeding in the GI tract is where it manifests and how it manifests. If blood uh, or if there is bleeding in the upper GI tract, they will lead to vomiting up of blood, and the vomiting up of blood is called hematemesis. Hematemesis is seen with the presence of coffee ground-like appearance as shown on the left. On the right is a picture of bleeding from the rectum or around the rectum. When people bleed from the rectum, they leave fresh red blood in their stool. And that is what BRBPR stands for, bright red blood per rectum. The medical name of this phenomena is called hematochezia. So bright red blood per rectum is called hematochezia. I apologize for the unpleasant images. Now, nausea and vomiting and diarrhea are classic gastrointestinal symptoms. They are unpleasant, sometimes violent and projectile expulsion of gastrointestinal contents either from the stomach, which is vomiting, or the anus, which is diarrhea. There can be many causes, from food poisoning to more ominous underlying disorders such as cancers and iatrogenic reasons. Nausea is the feeling of impending vomiting and may be associated with retching, where a patient undergoes reverse gastrointestinal peristalsis but without expulsion of food matter. This may occur if there is no gastric content in the first place to lose. Vomiting is a reflex process. It has a complex mechanism mediated by two centers in the brain called the vomiting center and the chemoreceptor trigger zone, so VC and CTZ. It manifests as a forceful reverse peristalsis that empties the gastric contents. When it is violent, it can be projectile in nature. More information about the mechanism of vomiting is provided in the SWAY and as external references. Violent vomiting can also lead to rupture of the esophagus, which is called Boerhaave's syndrome or Boerhaave syndrome. Again, this is discussed in the SWAY. However, milder forms of still violent or repeated vomiting can cause tears in the esophagus, which are called Mallory-Weiss tears. Again, that is in the SWAY. Now, as far as diarrhea is concerned, it is the reversal of the normal net absorptive status of water and electrolytes from absorption to secretion. It is defined as an abrupt onset of 3 or more loose motions or stools per day and should not last more than 14 days. When diarrhea lasts longer than 14 days, it is called chronic diarrhea. Dehydration is the most serious repercussion to nausea, vomiting, or rather vomiting and diarrhea. Dehydration is significant depletion of body water and to varying degrees its electrolytes. The symptoms and signs include thirst, lethargy, dry mucosa, decreased urine output, and as the degree of this dehydration progresses, people will start seeing tachycardia, hypotension, and eventually shock. This can happen from so many conditions, from infections to lack of hormonal influence. For example, the lack of mineralocorticoids can lead to this very phenomena of dehydration, hypotension, shock, and eventually death. So the diagnosis is based on history and physical examination plus laboratory examination of substances such as aldosterone, which is a mineralocorticoid secreted by the adrenal cortex. Treatment would be, first of all, to replace orally or via IV the fluid and the electrolytes that have been lost and treat other underlying conditions that contribute to this process. The physical therapy relevance is that dehydration results in electrolyte imbalance and from other conditions such as heat. Electrolytes mediate many of the neurologic functions of the body and also the water homeostasis. Therefore, impairment of the electrolytes can lead to direct influence on strength and thereby the motor system or the movement system. When people are, first of all, managing patients such that they don't get into a dehydrated state, and then once it happens, then quickly replenishing water with electrolytes is very crucial. If a person starts demonstrating signs of confusion and passing out or orthostasis, it is time to ring the medical defense. The disorders of the gastrointestinal tract are discussed in the SWAY depending on which body part it comes from. When we look at the major impairments or diseases or disorders of the GI tract, we talk of just the important ones that you should have a concept of in this course. And that ends this presentation. Thank you for your attention, and I direct you to move on to the sway.